Welcome everyone to this webinar today focused on maintaining stroke as a priority. I'm Sarah Belson, International Development Manager at the World Stroke Organisation, WSO, and it's my pleasure to host this webinar today, brought to you by WSO, the World Stroke Academy, and Stroke Connector, the new online hub for WSO members. The webinar will run for an hour and will be recorded and available on the WSO website. After the presentations, we'll have a Q&A session moderated by one of our speakers, Stephanie Mohl. Please post your questions as we go along in the Q&A function, which is available at the bottom of your screen, rather than in the chat function. If you post your questions throughout the presentations, it will help us to manage the Q&A session at the end. So this is the first of a series of 3 webinars and contributes to WSO's priority to build awareness and knowledge of stroke. The key topics of the webinars will be the impact of COVID-19 on people with lived experience of stroke across the stroke care pathway, informed by the WSO Global Stroke Guidelines and Roadmap, responses and innovations, including those of stroke support organisations, to the needs of people with lived experience of stroke. And we will highlight and signpost to patient education resources and activities that have taken place globally. So the 3 webinars will focus on 2 stages of the stroke care pathway. Webinar 1 today, we'll look at pre-hospital emergency and inpatient care. Webinar 2 will look at stroke rehabilitation and community participation. And webinar 3 will look at discharge and transitioning home and secondary prevention. And we'll give you more details of webinar 2 and 3 at the end of this webinar. So our speakers today are Miriam Silva Lima and her daughter Ana Flavia Lima from Porto Alegre in Brazil, Stephanie Mohl from the American Stroke Association, and Dr. Sheila Martins from the Brazilian Stroke Network. And we're really pleased to start off this series of webinars today by sharing the experience of Miriam Silva Lima, a stroke survivor, and her daughter, Ana Flavia Lima, who is a psychiatrist. Miriam and Ana recorded the following video for this webinar, and thank you very much to Sheila for the translation.
Boa tarde, pessoal. Meu nome é Ana Flávia e eu estou passando por aqui para dividir com vocês um pouquinho sobre a história da minha mãe, que tem 87 anos e apresentou um AVC em meados de abril, quando estavam começando a crescer os casos de coronavírus na nossa cidade. Inicialmente, ela teve um pouco de perda de força na perna esquerda. Ao longo daquele primeiro dia, ela melhorou, mas depois de uns 2 dias começou de novo com esse quadro e com um pouco de perda de equilíbrio, e nós ficamos na dúvida do que fazer. Eu mesmo, sendo profissional de saúde, tinha um certo receio, né, de levá-la para o hospital e ela correr algum risco de se expor ao coronavírus, mas ao mesmo tempo sabia que quanto antes ela fosse avaliada, melhor seria em termos de prognóstico se ela precisasse de um tratamento para AVC.
Meu nome é Miriam Aparecida Barros da Silva Lima. Tenho 86 anos.
Oi, mãe. Então vou começar te perguntando o que tu estava sentindo quando teve o AVC.
Eu senti a perna dormente, não conseguia me firmar nela. conseguia me equilibrar.
Então, mãe, tu falou, né, que começou a ter a dormência e foi ficando com mais dificuldade para caminhar. Então, nós decidimos te levar para o hospital para fazer uma avaliação. Tu ficou com medo de pegar o coronavírus, de ir para o hospital? Como é que foi isso?
Na verdade, eu fiquei apreensiva. Mas quando entramos lá na entrada do Ruins, até perguntei para o Marcelo o que eram aquelas tendas. E ele me explicou que ali era para o pessoal com possibilidade, né, de ter o coronavírus. E aí até me acalmou mais.
Bom, então tu tá me dizendo que tu te sentiu segura, porque quando chegou lá, viu que a emergência onde tu ia ser atendida era separado dessas tendas.
Era bem independente da outra ala.
Sim, da ala dos pacientes que estavam sendo avaliados para o coronavírus. E quando tu foi internada, como é que tu te sentiu durante a tua internação?
Eu fiquei mais tranquila quando eu vi que a CTI e a internação era bem independente do outro bloco, que era o bloco do coronavírus.
E agora, como é que tu estás te sentindo?
Melhor, fazendo fisioterapia, consigo caminhar bem mais segura, estou me sentindo bem.
E qual a mensagem que tu quer dizer para as pessoas que estão com medo de ir no hospital por causa do coronavírus?
Eu acho que as pessoas devem isso, porque senão vão sempre ficar nessa insegurança que não leva a nada. Então o melhor é ir e a gente tomar já um rumo certo nas coisas.
Bom, pessoal, vocês viram então, pelo depoimento da minha mãe, que ela teve um ótimo atendimento e felizmente após 2 meses ela já está praticamente recuperada. Durante a internação, tanto na emergência como na CTI ou quando ela esteve internada, essas alas eram separadas da ala de atendimento COVID, os profissionais usavam equipamentos de segurança, então podem ficar seguros que os hospitais seguem protocolos para não expor os pacientes a algum risco de se expor ao coronavírus. Eu tenho certeza que a recuperação da minha mãe se deve principalmente ao bom atendimento que ela recebeu de profissionais qualificados e também porque, mesmo eu sendo profissional de saúde e ter ficado na dúvida de levá-la para o hospital, eu consegui enfrentar esse medo e levei o mais rapidamente possível. O AVC é uma doença que pode evoluir de uma forma grave e o quanto antes o paciente receber atendimento, isso vai influenciar muito na recuperação e no prognóstico dele. Então não tenham medo, levem seus familiares se apresentarem algum sintoma para receberem avaliação e tratamento adequado.
So thank you so much to Miriam and to Anna for sharing their story with us. A really important message that at a time when many of us are experiencing fear and uncertainty, we need to know that stroke is a medical emergency and our hospitals are managing risks and maintaining stroke care. So thank you again, Sheila, for organising the video, and please pass on our thanks to Miriam and Anna for sharing their experience. So I'm now going to hand over to Stephanie Mohl, who will present on pre-hospital emergency in the time of COVID-19. Stephanie currently serves as Vice President of the American Stroke Association. The American Stroke Association was created in 1998 as a division of the American Heart Association and is devoted to saving people from stroke, the #2 cause of death in the world and a leading cause of serious disability. Prior to assuming her role at the American Stroke Association in 2016, Stephanie worked as a senior government relations advisor in the American Heart and Stroke Association's Office of Federal Advocacy for 11 years. So over to you, Stephanie. Thank you.
Thank you very much, Sarah. Let me share my screen. Great. Thank you. And thank you so much for sponsoring this webinar, and Sheila, to you for providing that wonderful video. I'm going to be talking today about how we can maintain pre-hospital care as a priority during this global pandemic. I have no financial interests or relationships to disclose other than my employment with the American Stroke Association. In the pre-hospital realm, the most pressing concern is that fewer people with strokes are calling for an ambulance and presenting at the hospital. In the United States, EMS data, emergency medical services data, shows that there was a 20% drop in stroke calls between January and mid-April of 2020. And a more recent report from our Centers for Disease Control and Prevention found a 42% decline in emergency department visits overall during the peak of the pandemic period in April. In this presentation, I am mostly going to focus on how stroke support organizations and the WSO are working to keep stroke as a priority by addressing this problem and sharing lessons and tips from the ASA's work in the United States. This concern has validated in the scientific literature. I think we all began hearing stories very quickly from our healthcare professionals who work with stroke patients that they were seeing a decline in stroke. And although it's possible that there's been a decline in stroke incidence, I think that most experts do believe that it's because more people with strokes are staying at home due to fear of the coronavirus. There are a number of articles that have appeared in the scientific literature recently. Here are 4 examples that come from our journal Stroke from around the world, finding that patients are presenting less at the hospital, and that decline has been anywhere from 20% to 50%. So for example, you can see that in China, there was a 40% decline in emergency department presentation. In stroke, authors reported a 23% drop in stroke hospital admissions. In an article that was co-authored by Dr. Sheila Martins, my co-presenter today, they saw a 36% decline in emergency department presentation. And in one region of the United States, in Northeast Ohio, there was a 30% drop in emergency department presentation. Early on in the crisis, the media and even public health officials here in the United States were telling people to stay at home. And I think what we learned very quickly was that people were taking that message very, very literally, and that we needed to adapt that message in order to overcome the concern and doubt that people were fearing about not coming to the hospital. So very early on, when we started hearing that this was a problem, we started adapting our messaging around stroke warning signs. But we also thought that it was important to really understand what was happening, and in particular what the public attitudes were. Certainly initially, we were just monitoring social media and seeing people saying that they were afraid to go to the hospital, much as we heard Miriam and Anna expressing that concern in the video. But we did also want to try and validate that in a more, slightly more objective way. And so the American Heart Association and American Stroke Association recently launched a survey Unfortunately, I can't share all of the results with you yet because they are embargoed, but I did want to share just a little bit of the information that we learned. So one of the questions we asked was about whether if you wouldn't call 911 during the COVID pandemic, what was the main reason that would stop you from calling? And as you can see from this slide, and I think it's no surprise, because it really does validate what Miriam and Anna shared, was that nearly a quarter of people responded that there was some COVID-related reason why they would not call 911 or call for an ambulance. We broke that down a little bit further, and in particular, 9% of respondents said that they wouldn't call 911 or call emergency services because of fear of getting infected at the hospital by the coronavirus. But interestingly, an equal number of people, 9%, said that they would not call 911 because they were worried about being alone at the hospital and not being able to have family members attend with them at the hospital. And so I think that was a very important insight that we learned, and that we've also heard anecdotally from patients. And it's a harder one to overcome, but I think it's one that we definitely need to try to address with our messaging. So we talked about what is the solution. Our solution at the American Stroke Association, and I think at many stroke support organizations around the world, has been to adapt our existing warning signs messaging to emphasize that stroke is still a medical emergency and that hospitals are still the safe and the best place to be, even during this COVID pandemic. And the American Stroke Association did this by leveraging our existing campaigns. We started out in April, as soon as we started hearing about the concern, ramping up our warning signs messaging using the FAST acronym, but tying it directly to the COVID pandemic and emphasizing the importance of knowing the warning signs and calling 911. But then we had already been working on our May American Stroke Month campaign and had already planned to elevate our FAST messaging during that May campaign period. So we just quickly worked to tweak our messaging for that campaign to make sure that it was relevant to what consumers were seeing and hearing during the pandemic, but that would also be empowering and motivate them to take action, specifically by calling 911 if they thought they or a loved one was experiencing a stroke. The first way that we really started activating was through our social media. I think that's for many of us the easiest and quickest way to do that. So we didn't even need to create new graphics or new social media creative. It was really as simple as just tweaking the post copy to that important message that strokes are still a medical emergency, and that calling your emergency medical services number or presenting to the hospital is still the best course of action to take. And I know many other stroke support organizations around the world are also using social media to get that important message across. Here is another example from the Singapore National Stroke Association, showing how they've been promoting the stroke don't stay at home message via their Facebook page. I think it's also important that if you have the ability, that you partner with other organizations that have a similar problem to get the word out. And in particular, other medical emergencies like heart attack are facing the exact same problem. And so for us, it made a lot of sense to partner with our parent organization, the American Heart Association, on a new campaign that we have now launched called Don't Die of Doubt. I was interested to see both Miriam and Anna using that word doubt, and that was keeping them from going to the hospital. So I think that's very similar to what we've heard from consumers as well. So in partnership with the American Heart Association, we just launched our Don't Die of Doubt campaign last week on June 15th. And it's really intended to address at a pretty high level the fears and concerns that we know that consumers are feeling. We knew that we didn't have time, and that time was of the essence. So we didn't have time to go through the entire campaign creative process that we would normally go through by doing market research and testing lots of different creative. So what we decided to do was adapt a campaign that we had done in 2015 on a regional basis that was called Don't Die of Doubt, rather than starting from scratch. And so we did significantly tweak the messaging to make it relevant during this COVID pandemic. So as you can see, here are some examples of the campaign assets that we now have available here. We have a couple of different TV broadcast PSAs. We also have radio PSAs that are available, as well as out-of-home billboard creative, digital campaign creative that we are running paid digital ads across the web and across our social media channels, as well as more traditional print ads. And you can see some of the other examples of resources that we've made available to our staff across the United States in that right-hand column. All of these assets are, of course, available in English, but we are also working to translate them into Spanish and hope to have the Spanish versions of these assets available very soon. We have also had a lot of success in pitching stroke-related stories to our media. As you all know, earned media is a very effective way of getting the message out to a very broad population. And in the case of this global pandemic, we've actually found it quite easy to get the message out using some of our national media outlets, both TV and print media. Particularly with the news and the early research that was suggesting that some stroke patients or some younger people in particular who had COVID were having what appeared to be coronavirus related strokes, and so that to emphasize the importance of everyone knowing those warning signs and being on the lookout for them even while they were sheltering at home. Of course, it's also important that organizations not overlook their own channels. And I know our other stroke support organization, sister organizations are not doing that, or that they are using their own channels. Here are just a few examples of the way the ASA has used some of our resources. Of course, we have information on both the American Heart Association's website as well as the ASA's website, stroke.org, about fast and heart attack warning signs, as well as the Don't Die of Doubt resources I just shared with you, but also making sure that we are literally exercising every single channel that we have available to us. All of our different e-newsletters, all of our different social media channels, and including some other owned resources that we perhaps wouldn't typically take advantage of. So for example, If you have a call center or a 1-800 number, one simple and effective change that we've made is just to update our on-hold call messaging to our where we tell people, if this is a medical emergency, you should hang up and call 911. We've just tweaked that messaging now so that if you call our 1-800 number and you're waiting to speak to one of our operators, that you hear the message that even during a pandemic, heart attacks and strokes are still a medical emergency, and that calling 911 is still the right step to take. So that was, literally something we were able to do for free, and gets the message out to, the 20,000 people who call our call center every month. We just did some simple things like creating this Zoom background that you can see to help get the word out about FAST, and keep that front and center while so many of us are spending our time on Zoom these days. And then also utilizing channels like our online support network, which is our virtual support platform, virtual support group, if you will, for stroke survivors, as well as for heart disease survivors. So there's a variety of the ways that we have worked to get the message out to consumers and patients generally across the United States. I did also want to mention just very briefly that we do also have some resources available for emergency medical services and other healthcare professionals specific to the COVID pandemic. And I know Sheila is going to talk a lot more about acute treatment of stroke and how that treatment has needed to adapt during this time. But we do have some specific resources that might be of interest to you about how routing of stroke patients to different stroke centers, or how EMS services have needed to adapt somewhat during this time of COVID. So you can find all of those resources on our website. I've included the link in this presentation, as well as a screenshot of the resources and names of some of the things that you might find helpful from an EMS pre-hospital perspective. I did want to also highlight that the WSO also has a lot of great resources available to help educate both healthcare professionals and the public about stroke. There's a link to the online articles that they have on their website about stroke care and COVID. A number of video messages that they have developed with the Don't Stay Home for Stroke message. I've included screenshots of those videos. There's also a template letter to be sent to health ministers to encourage them to prioritize public awareness of stroke during this time. And then the general World Stroke Day campaign website has lots of resources on stroke prevention, which of course is always important, but even more so during this time. And then our sister stroke support organizations also have resources that I wanted to share with you. So for example, the Heart and Stroke Foundation Canada has some best practices guidance that they've put out for healthcare professionals. The National Stroke Foundation in Australia has been doing some great work and sharing some videos and PSAs that they've developed via social media. They have a video that you can see to the right featuring the Governor General of the Commonwealth of Australia emphasizing the importance of recognizing FAST and getting to the hospital quickly, which was an awesome way to engage a very influential stakeholder. And then the Stroke Association in the UK has lots of resources as well on their website and through their social media, and some examples of how they have adapted their resources to get the word out about the importance of knowing the warning signs of stroke. So that is the end of my presentation. So I'm going to now stop sharing and turn it back over to Sarah.
Thank you, Stephanie. A really comprehensive insight into pre-hospital and emergency care during the time of COVID. Not only the work that you've been doing and continue to do at the American Stroke Association, but also what's happening globally with other stroke support organisations. And I think for me, some of the take-homes of what you've been saying is really thinking about how you can work quickly and adapt quickly and leverage existing resources and build on the partnerships that you've already established over many years. And I think some of those lessons are really, really important for our SSO community and other organisations that are involved in raising awareness of stroke and stroke as a medical emergency at this time. So thank you so much, Stephanie. We'll come back to you at the end. So now I'd like to introduce Dr. Sheila Martins, who has a very extensive CV, and she'll present on inpatient care. So Sheila is an MD and PhD and professor at the Federal University Rio Grande do Sul, head of neurology and neurosurgery at the Hospital Moinhos de Vento, president of the Brazilian Stroke Network, president of the Ibero-American Stroke Organization, and last but not least, vice president for stroke support organizations at the World Stroke Organization. So I'll hand over to you, Sheila. Thank you.
Thank you, Sarah. It's always wonderful to work with you, and it's wonderful to see American Stroke Association showing all potential and powerful resources they have to improve stroke care and to help patients and population to be aware about stroke. I will talk now about inpatient care in the COVID pandemic, my disclosures. So, World Health Organization announced COVID-19 as a pandemic in March 11, and our lives changed. We had social isolation after we have to use masks everywhere. We cannot travel more. We cannot meet or see our friends and our family. So our life changed a lot since then. What happened inside the hospitals because of the pandemic? Reorganization of hospitals to assist COVID patients, restructuring for massive COVID care, creating in some countries COVID hospitals, resizing of the emergency service, and a lot of emergency disease were not treated or were neglected. Were created new pathways for COVID and no COVID patients, new areas for COVID and no COVID, and cancellation of all no urgency activities, outpatient clinic, elective surgeries, everything reorganized because of the pandemic. And university closure in teaching hospitals, so is very different than before. Also, administrative professionals are working at home in several hospitals. In the first moment, decreased the number of health professionals in the hospital, sharing on-duty activities, but in the second moment, we have to increase our activities because of the number of infected professionals, and it happens in several different countries, several different hospitals during the pandemic. Less people visiting the patient, avoid multidisciplinary round with the patient, avoid the students, and in some hospitals, avoid visit to the hospital. The hospital is only for the health professionals and for the patients and not for the families. More virtual rounds to avoid a lot of people in the same area. We need more equipment, more intensive care unit beds that is available in several developed countries, and it was too hard to developing countries. We need more ventilators in the whole world. We need more masks, so we need equipment, personal equipment for protection. We increase a lot the use of telemedicine for pre-hospital, acute care, for several disease prevention and rehabilitation. In some countries, the telemedicine, it was not allowed. And now they can use telemedicine for different parts of the assistance, including in Brazil. The telemedicine was very difficult. It was allowed only doctor to doctor, but now is allowed doctor to the patient because of the pandemic. And what about the stroke? We had the social isolation, the message stay at home, that is very important because of the dissemination of the disease, but for a stroke is a terrible message, and we have to aware the population that the stroke don't stay at home, as Stephanie told you. With the creation of COVID hospitals, some areas were lost. Stroke units, neuro ICUs were changed to assist COVID patients. And some hospitals are outpatient care, health professionals telling to the patients with minor strokes and TIA to go home because it's dangerous to go to the hospital. So a lot of things to change in the view of the population, in the view of health professionals, that stroke is there, is here, and you have to treat the stroke during the COVID-19 outbreak. World Stroke Organization survey show a reduction in 40% on stroke inpatient admissions in stroke centers across the globe. This is the numbers at the end of the April. We have in the first weeks, we have a reduction of 60% of stroke patients admissions. This paper was published yesterday in International Journal of Stroke from a database, a platform that collects electronic medical record from different health organizations from US. You can see here 66,000 patients with a stroke in the first 4 months in 2019 in black left. You can compare with September to January, 50,000 patients. And when we start the pandemic, here you can see almost 38,000 patients. So we decrease 51% the number of admissions for stroke from the same period of last year to now. And we decrease in 35% if you compare the last years of 2019 to the numbers now. So we really decrease the number of patients that are arriving in the hospitals, and this is a huge problem for the treatment. The treatments was decreased the number of thrombolysis in 51%, the same compared to the same period last year, and decreased the number of thrombectomies. And we know that possibly it's possible that COVID-19 increase the severity of strokes, increase the possibility of patients have strokes, so patients have to go to the hospital. Is very important. We have this publication in Brazil too with the Joinville people. They show in the same, compared to the same period last year, decrease 40% of stroke admissions, mainly TIA, mild and moderate strokes, and severe strokes are arriving, but too late to receive treatment. So it's a very important information. We are running a survey in Brazil now for stroke survivors to know the situation now and to know the needs in this period. And we see here in red and blue that we have almost of people afraid to go to the hospital because of COVID-19. So we have to aware this population that they have to go to the hospital if they have stroke signs. And about the stroke, the organization inside the hospital, we reorganized the hospital with new pathways also for stroke patients, COVID and non-COVID. We have cancellation of all non-urgent activities, outpatient clinic only for a small number of selected patients to receive anticoagulation. In Chile, they have a very good national program for COVID time to give new oral anticoagulants for patients with anticoagulation to don't go to hospital in this time. So it will be a very, very good initiative for these patients. And new areas COVID with several neuro ICU and stroke units across the globe used as COVID areas. So the majority, we have our stroke units yet, but in some hospitals with massive number of COVID patients, they need to transform in areas for COVID patients. Here's the example of Barcelona from Carlos Molina that create an area for COVID patients with stroke and other area for no COVID patients after a PCR for COVID when the patient arrived in the hospital. But in some time in the pandemic, 80% of hospitals were COVID positive. So it was huge in Spain and several other countries in the world, we have the same situation. What changed in the world? Several new guidelines, temporary guidelines to change the pathways and the protocols to assist the stroke patients. You can see here the American Stroke Association new guideline for this. You can see here the Canadian Stroke Association guideline, Stephanie already showed. You can see here the Singapore guideline. Here the Ministry of Health guideline to assist patients during the pandemic, including pre-hospital, hospital, and after discharge for prevention and rehabilitation. Is a wonderful program from Chile. And here is our national guideline for this time, when usually the stroke teams create new pathways for the patients. First, to decide who patients should be tested. In some countries, as United States and Spain, in Barcelona at least, all stroke patients receive PCR to know if they are COVID or not, but in several other, we have to decide which patients should be tested for COVID. Mainly patients with symptoms or confirmed or suspected case in previous contact in the last 14 days, and also for stroke patients with aphasia or patients without information about symptoms of COVID. At least these patients should be tested when arrive at the hospital and to be in an isolated area until positive or negative tests. So create new pathways for investigation and treatment of patients during this time too. About investigation and emergency room, usually for primary stroke centers, only with IV thrombolysis, they use only CT scan. The majority of comprehensive stroke centers use CT and CT8, and the suggestion was to include a chest CT scan to evaluate the possibility of COVID-19 on these patients when arrival at the hospital. About treatment, the majority of countries maintain the same protocols for thrombolysis and thrombectomy, but some countries, as we know, that COVID patients probably has a worse outcome when treated. Some countries are deciding, depending on the characteristics of patients with COVID, if they should be treated or not treated with hyperfusion therapy. Etiological investigation, we reduce the time of investigation to go to home as soon as possible. So including cervical vessels, imaging, EKG, no Doppler echocardiogram for all, only selected patients, and no transesophageal echocardiogram only for endocarditis suspect, because increase a lot the possibility of infection of the people that is performing the examination. A suggestion for locals without investigation for COVID in all stroke patients, to investigate at least that patient with cryptogenic strokes, because we think, and we saw in the last publication, that it's possible that COVID can increase the possibility of stroke mainly in young patients, and it's possible that we have patients arriving with stroke with COVID without respiratory symptoms. So it's possible that inclusion of COVID test for cryptogenic stroke will help in the diagnosis. It's very important the safety of health professionals in the emergency room and also in the stroke unit, but for the stroke code, we need full protection. The problem is some areas we have low resource. We don't have enough protection, personal equipment protection. So in areas with low number of cases, they are using surgical mask or face shield. In areas with high number of cases, N95 mask, face shield, non-sterile, disposable, full sleeve isolation gown, 2 pairs of gloves and surgical cap. And here you can see Pablo Lavados, our friend, stroke neurologist in Chile, assisting patients 2 days ago with full equipment. In Brazil, the COVID-19 pandemic started in February 26, the first case. World Health Organization annunciated as a pandemic in March 11. In March 16, schools were closed. In March 18, we started social isolation. We have more than 200 million inhabitants with huge difference in different parts of the country, social, cultural, and economical. This is the number of cases we have in Brazil now, more than 1 million patients confirmed and 5,000 deaths. And our curve is increasing yet. Is different in different parts of the country. Some parts are better. North and northeast of the country is worse, with several cases, with less resources, with more poor population. We create tents outside of the hospital to evaluate COVID suspected patients without to put together with the emergency room. You can see several initiatives across the country. We create hospitals, new ones. We increase a lot of the number of intensive care unit beds in the country to support the pandemic. Here is Leticia, my friend. She has been trained, as all of us, to assist COVID patients. And we start like this. Here are my stroke neurology friends. And now we are like this with much more protection. Here's in the angel suite. And here we are inside the hospital. Here I'm arriving in the hospital. We start to prepare to assist patients there. We are like this every day. And we have intensive care unit, big pictures to the patient, know who is the person that is helping him. Telemedicine increased a lot in Brazil, allowed use in different areas, including for consultation, and use it for acute care a lot too. We use intensive care units in several hospitals in Brazil. Only intensive care physician can go assist patients. So you use telemedicine for round with doctors inside the intensive care unit and outside, and discussion and conversation of patients and families that are not allowed to go to the intensive care unit. You use telemedicine also to help other hospitals without experience, with least experience, and use ventilators, and with treatment and in intensive care units. You can see here an intensive care unit in north of the country, helped from our hospital in south of Brazil. Ministry of Health create an app to monitor the patients with symptoms in Mohl. Outpatient clinics by telemedicine for patients with chronic disease, including the public hospitals, starting May by universities and Ministry of Health. So we are using telemedicine for acute stroke to communicate inside the hospital to treat patients, but also for prevention. Unfortunately, we don't have plans for rehabilitation after discharge. We have several missions to help in other parts of the country with doctors traveling, mainly intensive care physicians and emergency physicians to help in the management of severe patients in other parts. Here's in the mission Amazonia. And what else? To aware the population, we create several videos to show the importance to go to the hospital. Here is a video I created in the start of April with more than 200,000 views. This is Angel's video from Brazil. O AVC é uma das principais causas de morte e incapacidade no Brasil e no mundo.
Mesmo no momento do coronavírus.
Desde o início da pandemia, as internações por AVC têm diminuído drasticamente em muitas regiões.
Sem o tratamento adequado, muitas pessoas correm o risco de morte ou incapacidade.
Stroke don't stay at home in different languages, in different parts of
os seus entes queridos são as coisas mais importantes para se preocupar.
Os hospitais possuem protocolo de AVC em vigor.
Existe um caminho seguro para pacientes com AVC em todos os hospitais.
E obter a cura para evitar as consequências de um AVC.
Tell to the patients that they should go to the hospital that is safe to
Diante dos sintomas de AVC, é muito importante agir rapidamente.
Se você sentir sua boca ficando torta repentinamente,
se você sentir dificuldade de fala,
se um braço ficar fraco,
chame o SAMU 192.
Estamos aqui, prontos para ajudar.
O AVC não pode esperar.
Compartilhe essa mensagem.
AVC, não fique em casa.
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 That's a strong message to the population, and has been recorded the similar video in different parts of the world in different languages to aware the population. Other interesting and important initiative was the Global Stroke Alliance, was a joint of efforts with the aim to stimulate a global alliance to improve stroke care worldwide and to discuss the best strategies to implement evidence-based interventions in all levels of continuum care. It was organized in Rio de Janeiro when exploded the pandemic in name of World Stroke Organization with support of several other partners, 20 countries represented, researchers, health professionals, health managers, scientific societies, private hospitals, industry, and patient associations, with almost 600 participants in person and several by teleconference. When we finished this meeting during the pandemic, it was a subject of editorial for Lancet Neurology, talking about the importance of this meeting, the main goals of the meeting, and telling us that the fight against the stroke must go on mainly in this time, in this pandemic time. So it was an inspiration to create the Global Stroke Alliance. The Fight Must Go On, a virtual program that we start in April with lectures for population with stroke associations. You can see here Solange, Sandra, Carla, that are coordinators of stroke associations in Brazil, stroke support associations. We launched the Stroke Don't Stay at Home on this day, covered by media. And we launched the Stroke Guide, a line of communication to support questions and answers about the stroke to the population. we start the health professionals discussion about how to organize COVID time stroke care. We start with Carlos Molina, after Raul Nogueira from Emory in Atlanta, after Vitor Urrutia from Johns Hopkins, and here Sheila that has a national program from Ministry of Health, helping each other to modify the plans and the pathways to assist stroke patients. We start the education, a continuous education for stroke, a basic one in Portuguese and in Spanish, with almost 1,000 people connected once a week to discuss the main pathways for acute care. We have international participation with experts lectures. Here, Gregory Alberts participated with more than 500 people connected, talking about advanced neuroimaging in stroke. And we have the global resource. World Stroke Academy is a very important tool to help people to learn about stroke, about acute care, about stroke unit, about rehabilitation, with webinars and with recorded lectures that you can see here. And here we launched also last year a Spanish teaching course. That's the idea, is to help people to be connected and to learn in this very difficult time. Other very important tool of World Stroke Organization, Stroke Support Organization, coordinated brilliantly by Sarah Benson, connecting all the stroke organizations and helping them how to improve and how to get resources and how to help the stroke patients, stroke survivors. And just to finish, remembering that you have a very difficult time now, and we will have much time, I don't know how much, but some good things you can have from this difficult time. One is to be connected frequently globally. Another is to be with our family, discussing and talking more than before. You can see.
Não quero lhe falar, meu grande amor, das coisas que aprendi nos discos. Quero lhe contar como eu vivi e tudo o que aconteceu comigo. Viver é melhor que sonhar, e eu sei que o amor é uma coisa boa, mas também sei que qualquer canto é menor do que a vida de qualquer pessoa. Por isso, cuidado, meu bem, há perigo na esquina. Eles venceram e o sinal está fechado para nós que somos jovens. Para abraçar meu irmão e beijar minha menina na rua, é que se fez o meu lábio, o meu braço e a minha voz. Você me pergunta pela minha paixão, digo que estou encantado com uma nova invenção. Vou ficar nesta cidade, não vou voltar pro sertão, pois vejo vir vindo no vento o cheiro da nova estação, e eu sinto tudo na ferida viva do meu coração.
So we are much more with our families, and please believe these days will pass. Thank you.
Thank you so much, Dr. Martins, for that terrific and very, very informative presentation. There are a number of questions that have come in, and one of the questions I want to pose to you is actually about the videos that you have done, and I think particularly the one that you shared at the end. One of the questions is wondering if the videos could be even stronger to have families and stroke survivors who did attend during this time to support the message. I think sort of similar to the message that Miriam and Anna shared.
Yes. Yes, I agree. The idea is to have other videos, because this one we record very fast to launch the message, and now we are preparing videos together with patients and families of patients, and to be more strong. I agree.
Absolutely, yeah, and I think we're all discovering how quickly we can record videos, but there's still plenty more work to be done. Another question that came in was related to the point that I made about people being afraid to go to the hospital because they can't have a family member with them. And so one of the questioners was wondering about, reassuring the public about guaranteeing contact or update with family members via Zoom once they're at the hospital. So Dr. Martins, I'm wondering whether the hospitals in Brazil or your hospital is making that kind of video contact available with inpatients?
Yes, as I saw, we are using telemedicine for these patients inside the intensive care unit can connect families outside the intensive care unit. And when we, here in my city, we are better than several parts of the country. So here we start to have visits for COVID patients, but I think it's very difficult, and it's better the connection by telemedicine.
Agreed. And I know that there are hospitals here in the US that are doing the same thing, trying to keep patients connected with their family members. I would say that I think that, as part of a national public campaign, that it's important that we not overpromise to patients. And obviously we are all very sensitive to the burdens and demands that are being placed on our healthcare professionals these days. So we have to be a little bit careful about, what we guarantee, I think, to hospital patients, but I think anything we can do to, provide some reassurance. I think another thing that we've done to try and address that concern is just to sort of make the rhetorical point that, yeah, we understand that, not being able to have your family at your bedside while you're at the hospital is very difficult, but it's better than, a lifetime without your family members if you don't get your stroke treated. So. Yeah,
I agree.
There was another question for you, Dr. Martins, that's a little bit technical for me because I'm a non-clinician, but somebody who's wondering whether you're doing chest HRCT along with contrast CT or CT angiography in large vessel strokes as a routine during the pandemic.
Yes, several countries include the CT, CTA, and chest CT in the initial protocol, several, including here in Brazil. We include in several hospitals this protocol to evaluate the lungs in the initial evaluation.
Okay. And I'm wondering, now that we've got a couple of months of this pandemic under our belts, and it looks like it's going to continue for quite a while yet until we have a vaccine. What would be your advice to hospitals and to stroke healthcare professionals? Maybe one or two of the key things that you've learned that you think are most important.
To the health professionals, well, it's very difficult because I think we have to be very well protected. When we go to the hospital, we have to use masks, and now we know that it's important to use glasses too. So barrier method, glasses or face shield is very important. To wash the hands and to use alcohol to decrease the infection, to keep the social distance inside the hospital with friends. So and when arrive in home, to put the clothes to wash, and we have to have all this care when we are going to the hospital, treating patients and come back to home.
Yeah. And because of all of the needs to put on that personal protective equipment and potentially to do other tests like the chest CT, are you seeing a delay in door-to-needle time for stroke patients?
Yeah, when patients suspect of COVID, we increase a lot the door-to-needle time because everybody should be with the correct equipment, and we have to wait the COVID CT, so increase the door-to-needle time, yeah. Unfortunately, including for thrombectomy because they have to put a lot more equipment.
Yeah. Yeah. There was also another question for me, but also for you too, Dr. Martins, wondering about what key things enabled us to respond and adapt so quickly, I think with respect to the consumer messaging, the public-facing messaging around stroke emergencies. I think the one thing that maybe surprised me was just how much we've been able to get done even while we've all been working from home. All of my American Heart Association and American Stroke Association colleagues have been working from home since the middle of March. And, you know, we were used to producing our videos in studios with all the right lighting. And I think now we've just learned, you know what, we can still put out a pretty quality video and pretty quality informative product without all of the bells and whistles and frills that we used to think that we had to have.
Yeah, it's the same. We are working much more when we organize the session for the patients. They are afraid because the messages from US that stroke patients could be more affected and the COVID can cause a stroke. So in 2 days, we launch a webinar for the population so we can do fast and quickly. Yeah.
So since you mentioned some of the findings in the U.S. about COVID potentially causing strokes and particularly in younger patients, have you seen that happening in Brazil?
We don't know yet because you cannot test everybody. So probably we have patients that we don't know yet. We are trying to collect data from different hospitals to know about this, but we don't know yet.
Okay. Well, I think we are running out of time, but are there any last closing comments that you would want to make, Sheila?
Well, I think it's very important to be aware that stroke patients should go immediately to prepare hospitals, to stroke centers. And when arrive in the stroke center, we will have our independent route to assist these patients safely, because it's much better to treat now than have sequels to the whole life.
Absolutely. Well, thank you so much. And Sarah, thank you for inviting me to participate in this webinar. And I'll turn it back over to you.
Brilliant. Thank you, Sarah and Steph.
Thank you so much, Sarah, Stephanie and Sheila, and also to Miriam and Anna for sharing their story and their experience and their crucial message to other people affected by stroke at this time. And just to Stephanie and Sheila, your insights are vital. They're important for our stroke support organisation network globally. And we're really pleased that we'll be able to share this webinar for others to take a look at. I'm just going to give an overview now of the sessions that will be coming up over the next few weeks. So what we have webinar 2 on the 2nd of July. That's at 9 AM Singapore and 11 AM Melbourne, and we'll be focusing on stroke rehabilitation and community participation. And we'll have Professor Deirdre De Silva from the Singapore National Stroke Association and the National Neuroscience Institute, and Sharon McGowan, the CEO of the National Stroke Foundation Australia. And then our webinar 3 on the 8th of July, 9 AM Toronto and 2 PM London, will focus on discharge and transitioning home and secondary prevention. And Juliet Bouverie from the Stroke Association UK and Dr. Patrice Lindsay from the Heart and Stroke Foundation Canada will present. So we're going to close here. Just thank you very much for joining us, and we hope you'll be able to join our next webinars in the series in the coming weeks. Thank you very much. Bye-bye.
Thank you. Bye.